Another question from Alex, and this is not favoritism. This is just because I think it's a really good question. Um, Most diagnoses are unspecific and are impossible for us to know specifically and it's impossible for us to know specifically what the quote unquote problem is, as it could be a range of biopsychosocial factors. So how do you chart something like that while maintaining a comprehensive chart that meets college guidelines? And then in brackets, he asks, does the college always want a specific diagnosis? And because of that, does that put you in a dilemma? So just because Alex is in Canada, like, he's also referring to, and in Ontario, he's referring to the College of PTs of Ontario. But I don't think that's going to change much depending on what regulatory body we're talking about here. So, I mean, I agree with his initial premise that most diagnoses are unspecific, or we could say it differently in that if someone gives a very specific diagnosis, it would be extremely difficult, if it's possible at all, to support that without some really comprehensive testing, which the vast majority of PTs, I'm going to guess, probably don't have access to. We're diagnosing tendinopathies without being able to confirm them on imaging and all that stuff, trying to, recognize patterns and make best guesses. But they are educated guesses. We often, most of the time, can't confirm them beyond the shadow of a doubt. So, and then, of course, viewing this within a biopsychosocial framework, people aren't just a collection of bones, muscles, tendons, nerves, lymph, all that stuff. Like, they're people. They're all of those things, but they've got experiences, they've got expectations, they've got a physical and social environment. So how the hell do you figure out, what that problem is? And then how do you chart it? So I've become more and more of a fan over the past few years. Not that I've been treating for all that long. I've been in practice for 3 years independently. I think I started off charting things as being a bit more specific, like naming particular structures and pathologies going on there, and then realizing more and more that I really didn't know for sure if it was that thing that I was writing down in the chart, and going through more than a few existential crises about what I knew or didn't know, which still happens every other week, by the way. I decided to just go with, hey, shoulder hurts in the front, anterior shoulder pain, likely secondary due to whatever, if I think that there are some precipitating factors that led to it. Patellofemoral pain syndrome, I don't remember the last time I've written that. I've just written anterior knee pain or something like that, and any sort of factors, again, that seem relevant to that case. I'm pretty positive that meets college guidelines, and I try my best to upkeep my other records to be in accordance with college guidelines too. So we still have an analysis, we've got a problem list, we've got long-term and short-term goals, we've got an initial treatment plan, or an initial treatment on the first day if we get to it, and then, well, not if we get to it. There's always some component of education, which I count as treatment, because it should be. And then we've got a treatment plan. What do you plan to do with them over the next little while? In fact, recently I've tried to pull a little bit more from what the folks at Boston PT and Wellness do with their whiteboards. And for a few patients, we don't have whiteboards in the clinic, so I pulled out a few blank pieces of paper and have drawn out timelines. This is where we are now. Here's what our main focuses are for rehab exercises, for other factors for modification. Here's what we can expect the next little while. Here are your exercises right now. Here's what we're going to be doing in treatment for the next however long. So yeah, and also thinking back to PT school, I remember I think an upper year student, when I was going through, telling me that there was a good example of a supposed dichotomy with two faculty members, one of whom was of the opinion that you should always be able to find a specific diagnosis for every circumstance. And then the other one who was saying that you probably don't need to do that because it doesn't matter. And I think a good litmus test is, will a difference in specific diagnosis, or the presence or absence of one for that matter, will that change how you're going to treat them? And if the answer is no, then it really doesn't matter, does it? Because you're going to treat them the exact same way and operate using the same principles. So that latter option, where it doesn't matter so much, if you happen to have a specific diagnosis, like if someone comes to see you 2 weeks post-op left supraspinatus repair with subacromial decompression, cool, you know exactly what happened. And I tell patients that, like, hey, we're post-op. One of the nice things is that we know exactly what happened. There's no guesswork here, and here's what we do. But beyond that, saying that there's no guesswork, the process doesn't look all that different for me anyway. What do you think, Quinn?
Yeah, no, I think that was a great answer. And I'm going to refer, we had another question actually on Instagram from Dylan Carmody. It was a similar thing. How much does a diagnosis shape your rehab plan with a client? So we're just going to make two in one here because they're both pretty much the same. And I'm going to first start by referring to the Clinical Athlete podcast that we just did with Adam Meekins, because he and I talked about this very thing pretty much the entire time. The necessity, or the utility of a specific diagnosis in physical therapy, physio land. So check out that podcast. I am very much in line with you, Jared. I don't think that the diagnoses that we have in physical therapy are very specific, and I think they're largely diagnoses of exclusion. And basically what that means is we don't really know what's going on, and we can't pinpoint it to anything, and we don't have any tests that are reliable enough or valid to even define what's going on, and so we're just going to give something a name. Patellofemoral pain, chondromalacia, even patellar tendinopathy, like you said, Jared. When we're not, who cares if we're not seeing an image? Like, we can't confirm that. But all we know is that the symptoms are pretty much like it, and we can say, well, it's a tendinosis of some kind. But even that, it sounds bad. Like these diagnoses, just the words themselves kind of have this like nocebic connotation to them. The shoulder also, subacromial pain syndrome, impingement syndrome, tendinopathy. Going along the lines of what you said, do any of those diagnoses change the treatment? In medical land, if you're diagnosed with specific diseases like cancer or heart disease or whatever, there are generally a little bit more specific treatment routes that you go through. Like, you're not going to have the same treatment for whatever heart disease that you're going to have for bone cancer or malaria or whatever the hell it is. In physical therapy, we're not quite there. And I'm much more in line with you. I also have the benefit, like, I don't bill insurance here. I don't bill third-party payers in my clinic. It's all cash pay. And so I know that some clinics have the formality of having to kind of, their documentation has to be such that there's medical necessity. And there has to be a diagnosis in order for them to treat and in order for insurance to reimburse. And so in that realm, I know I've had this conversation with many clinicians who are like, my documentation is much more nocebic, diagnosis heavy, kind of medical jargon, but then my narrative to the patient is much different. It's like what you said, Jared. It's, oh, you're coming in with shoulder pain? I diagnose you with shoulder pain. Now let's talk about what matters, prognosis and plan. The pushback on this, and this conversation that I had with Adam on the podcast there's consent, there's informed consent here. Are we withholding information that would be an ethical issue? And so I've had pushback in these discussions with, well, if you're withholding, if they have some type of potential disc pathology, maybe they're flexion sensitive, maybe they have radicular symptoms, maybe not, but to say we should tell them there could be some type of disc pathology here, I don't quite know, because then I go back to the data and say, well, disc pathology is pretty darn common in the asymptomatic population too, and increases in prevalence with age. So it's almost like seemingly a normal occurrence with age. It's just kind of what happens, whether you have symptoms or not. So like, if I'm telling somebody that, does it really help them? If conservative care is changing and their symptoms are peripheralizing and their foot's going numb and their foot drop and there are circumstances in which obviously structure matters. But in most cases, I'm not sure the diagnosis helps us. I think, and tell me what you think about this, Jared. I have more trouble with patients that walk in the door who have already had a diagnosis or maybe multiple diagnoses and have had imaging. Like, they come in with MRI in hand and they're like, look at my back. Look at all the things, bam, 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 bam. And there's just like
many things.
So many labels that they now have ingrained into their head. They've now, their identity is now conditioned with those labels. And many of those labels are shit that I probably have in my back too. But they don't know that because the narrative has been different. So this is a really interesting conversation. I think it's one that will be had or continued to be had, and it's an important one. And that's just kind of where I am with it right now.
I totally agree. I was going to say, if you hadn't brought it up, I would have brought that up. Just, um, I make it a point, I mean, as every clinician hopefully does, to never lie to a patient. So if someone asks me point blank, like, do you think I have some sort of degeneration in my back? If they kind of, I don't know, maneuver me into a corner that way, I'll probably say, like, well, chances are probably pretty good because the research says that. And there's a really quick but that follows and says, like, hey, but here's what the research also says, and that, like, it's really common in people that don't have pain. So could it be relevant? Maybe. We don't know. And often they've come in with other labels, other diagnoses or previous images. And like you said, look, there's a disc issue, and like that happened, and it's around the same time as my pain started. I'm like, well, okay. First, I mean, I want to make it a point to validate what they're going through, right? And after validating their experience and that it's been really sucky up to this point, unless we had, you know, that same image before where that finding wasn't present, and then their findings or their symptoms happened, and then we had the same image right after, and there was a difference, maybe then we could demonstrate a correlation. But, you know, unless we have that, which almost certainly we don't. I'm trying to think of any instances where we would have that, but if we don't have that, then I can't say it doesn't matter, but I can also just point to what the research says, and that it probably doesn't change our treatment, and it probably doesn't affect our prognosis.
To me, I can't get past that. That's the biggest thing for me. Does it affect the treatment? I mean, isn't that what a diagnosis should do? That's the point, right? If you're labeling something, it's to subset it, and that would, I'm going to do something different because this is what's going on versus this is what's going on, so I'm going to do this thing. But if you're not going to do anything different, then what's the point of a label? Even to your example, what if somebody does have, like, it's clear as day, they somehow had an MRI 2 weeks ago that was pristine, like they just had an MRI machine laying around and their back was completely fine, never had back pain in their entire life. 3 days later, they pulled a heavy deadlift, and in an instant, they know the moment that it happened, on the rep that it happened, boom, got shot in the back, right leg went numb completely, foot drop, and then they got an MRI the next day, and just an obliteration of L5, S1. You know, sequestration, all the nasty stuff. Okay, cool, but does that really change? I mean, what does it change in the plan? Because the only thing that it changes is the fact that it's extremely acute, and that person's not going to be able to do a whole lot right now. But it's still education on timeline. It's still great exposure to the movement. There's not, to my knowledge, we don't have disc treatment. We don't have disc exercises. I know that I'm going to get pushback from the folks who, you know, prone press-ups are disc exercises. I'm going to argue that, because I think that regression to the mean is a disc exercise. I'm pretty sure that the worse a disc injury is, the more that it actually recedes and looks more normal over time, literally heals. And the less severe a disc injury is, a mild herniation is probably going to look the same forever, not much different, because the body doesn't care about it. So it doesn't, until we can actually treat as physical therapists who are on the outside of the human body, we're non-invasive treatments. We don't have scalpels and we don't have sutures and all these things. Until we have specific exercises that target specific tissues in different ways, I don't know what the label does for us.
Yeah, I'm in agreement.